Today we have with us Dr. B.K. Tripathi, who is a professor and ex-HOD of Department of Medicine, Department of Gastroenterology in Safdarjung Hospital. Today we will be discussing the topic that is irritable bowel syndrome. We come across a lot of CGHS beneficiaries with symptoms which are suggestive of irritable bowel syndrome. So the CME has been planned to help us understand the topic better and understand the latest treatment guidelines that are available for irritable bowel syndrome. I request sir to start the session, please.
Thank you, Dr. Nitya. Good afternoon to all my dear colleagues. In this new year, I bring best wishes for your prosperity and development of the new year. I apologize for slight delay because of the system error. We could not start just exactly at 4 o'clock, but anyway, I'll try to catch it up. The topic for discussion today is irritable bowel syndrome. Uh, Whenever you discuss this topic, whenever you pick up this topic to learn, to educate others, it's very surprising that most of the people do not. Uh, it's not a very interesting topic, and especially because of the reason that does not have any fixed physical symptoms and signs, no investigation, and the treatment is also most of the time is a failure. So it is not a very encouraging entity as far as clinical science is concerned. But still, there are lots of development and progression in last 5 6 years, which I would like to discuss with you, and probably it will help you in when you treat your patients of irritable bowel syndrome. Now, coming to the definition, basically it's a functional disorder. It is characterized by bloating, abdominal pain, and altered bowel habits. This abdominal pain is a very important and significant uh, issue for the diagnosis of irritable bowel syndrome, which I will be discussing right now. And the best part is this, that till date, there is no fixed biochemical or mechanical or inflammatory abnormality which is found to be associated with this clinical entity. Of course, in last 3 4 5 years, people have discovered some uh, uh, histopathological changes in large bowels and in other areas, which probably defines irritable bowel syndrome, and the number of association with other uh, large bowel diseases have been found, and which I will be discussing. It's a very common problem. It affects nearly 11% of the population worldwide, but in our country, maybe even more. Of course, I could not find any data in our country, but in America, it is in between 9 to 11%, and it is usually a disease of young. You can say that as young as 10 years of child and probably till 45, 50 years. Is a very important issue because if you find a 50 or more than 50 years old patient developing symptoms suggestive of irritable bowel syndrome, then probably you have to pause, you have to think twice before making a proper diagnosis of irritable bowel syndrome, because onset after 50 or 55 years is very unusual as far as irritable bowel syndrome is. Basically, it's a disease of young and middle aged people. How do we diagnose it? Say basically, for last 20 25 years, people have suggested a lot many criteria to make a diagnosis of irritable bowel syndrome. Rome 1, 2, 3, now it is 4, and Manning's criteria as well. So right now we are probably we have accepted Rome 4 criteria for making a clinical diagnosis of irritable bowel syndrome. Irritable bowel syndrome can be classified into 4 different categories, and surprisingly, very unusual manner, the classification is based on the type of a stool the patient is passing. So I will be discussing it right now. There are four types are irritable bowel syndrome constipative type, irritable bowel syndrome diarrhea type, then mixed type, and then unclassified. In 2021, American College of Gastroenterology have proposed a grading system of IBS, and they have picked up nine uh, research papers for the diagnosis, 16 research papers related to the therapy, and they have suggested a few things which helps us clinching a diagnosis of IBS as well as probably treating the patient more successfully. And the zero markers which they have suggested TTG and fecal calprotectin. But these two markers are not there to just to make the diagnosis of irritable bowel syndrome. They are there just to exclude any significant or serious illness related to large bowels. Like TTG is positive in cases of celiac disease, and fecal calprotectin is again a very good biomarkers which signifies any type of inflammation or infection in the body, especially colon. So if you are finding your patient with negative fecal calprotectin and negative TTG, probably you are more confident in making a diagnosis of IBS. Similarly, they have suggested a few things in the therapy. One is FODMAP diet. I will be discussing it right now. Chloride channel inhibitors like lubiprostol, it is available in India. Then guanylate, cyclase agonists like plecanide and linaclotide. Then rifaximin. All these modalities of treatment have been suggested by American College of Gastroenterologists, and we can definitely use it in our patients. Now coming to Rome 4 criteria for the diagnosis, which I have discussed earlier, please pay attention to this that the abdominal pain is the cardinal feature. Any the patient who comes with abdominal pain of at least 1 day per week in last 3 months, then probably it suggests the diagnosis of irritable bowel syndrome. And this is how you can differentiate with simple chronic constipation. In chronic constipation, most of the patients will not complain of abdominal pain. But if they are telling the complaints of abdominal pain and constipation, probably you have to find out whether the patient is really suffering from IBS constipative type or not. And there are three more sub criteria. Out of these three, at least two have to be present. That is pain related to defecation, pain related to change in frequency of stool, right? If the patient has been passing about, say, about last year, he has been very good in passing stools once or twice maximum in a day. Now, suddenly, in last 3 4 months, he has started having bowel movements 4 5 times in a day, and that too with the watery and little unformed stools. Then probably this suggests the diagnosis of IB or diarrhea type. And the third thing, sub criteria, is if it is associated with change in the form. So frequency as well as form. But please remember, do not jump on the diagnosis of IBS because there has to be history of at least for last 6 months. And this is suggested in Rome 4 criteria, which we are still obeying. But again, it's very, very important that before making a diagnosis of IBS, because in beginning it is innocuous and functional disorder, and definitely you are not allowed to miss any significant diagnosis with a serious or ominous position. And probably at that time when you are making a diagnosis, you should pay attention to certain important symptoms like weight loss, anemia, blood in stools. Blood in stools will never be seen in irritable bowel syndrome unless it is associated with inflammatory bowel disease. I'll be just telling you that many times IBS has been found to be associated with IBD. In that case, definitely you have to make a diagnosis of IBD first, and then you can side by side make that probably IBD is in remission, and now the symptoms of the patient are related to IBS. Chronic severe diarrhea, the patient has been passing loose stools for say about 6 7 months, and probably he is going to the toilet 8 9 times in a day, totally watery. Again, it's not a feature of IBS. Onset after 50 years, we have already discussed. Vomiting is not a consistent feature of IBS. Similarly, if there is history of colonic malignancy in family, probably you have to be careful, because colonic malignancy is seen to be having some hereditary patterns as well. There is some dislocation, just bear with me. There are certain investigation which probably everybody would like to go for, not to make a diagnosis of IBS, but just to exclude any other ominous diagnosis. And they are simply certain investigation which may suggest some inflammatory disorders like complete blood count, CRP, ESR, and fecal calprotectin, as I told you in the beginning. And this is a flow chart, but probably I'll not be discussing it right now because it has some parts is suggestive of some treatment. I'll be coming again to this flow chart. It's very interesting and will make you understand to to clinch the diagnosis as well as treat. So I'll be coming again to this flow chart. This is again how to approach a patient of suspected IBS. If the patient is coming with history of whatever we have just talked about, exclude all possibilities of any warning signs, ask repeatedly, because many times patient may not be coming out with his own at his own, that he is having, okay, I remember that probably I passed blood about 4 5 weeks before. He may have forgotten a small amount of blood. So definitely you have to explore the possibility of all these. So if the patient is giving history which is fitting with the criteria of room 4 criteria of IBIS, then go ahead and try to subclassify into which type of IBS you are probably encountering. And this can be, as I told you in the beginning, this can be classified only by asking the patient what type of stool he's passing. And in 1993, a Bristol stool chart has been prepared. And normally, if the patient of I suspected IBS is coming to you, should be prepared to show this chart to him that what type of stool you are passing. And you can see that there are seven different types of forms of stool the patient is passing. And uh, these forms of stools are suggesting a different diagnosis. Like if you see the type 1 and type 2, probably they are suggestive of IBS constipative type with the history of passing stools once in 2 days or once in 3 days. Similarly, if you pay attention to the type 6 and type 7 stool types, this is all mushy and watery. Probably it's a diagnosis of IBS diarrhea type. Many times they are alternating with each other. Like sometimes patient passes hard stools, sometimes after say about 3 4 days he start passing loose stools, watery stools. Then we classify it as IBS mixed type. And many times it is difficult to make a proper diagnosis, make a proper class of IBS you are dealing with. Then we put them in IBS unclassified. These are prominent symptoms: constipation, abdominal pain, bloating, and diarrhea. So the latter part is again dealing with the type of treatment we are offering. I'll be discussing later on. So I'm skipping at this stage. Now coming to the treatment, we require definitely a patient-centered approach, a careful, cost-effective patient evaluation. Why cost-effective? Because if you are clinically making a diagnosis of IBS, there is no need of going for expensive indications like MRI and CT scan, because you have to observe. You just go for exclusion diagnosis, and if the patient is not showing any other feature, probably you classify him in IBS. And in the Western countries, there are IBS schools where the such type of patients are invited to attend those IBS school. They will find other patients of IBS in that school, and the tutor always tell them that such type of features are more close to the diagnosis of IBS rather than any organic illness. So IBS schools are very popular in Western countries. Coming to the diet probably, let me tell you right in the beginning that diet is again very flexible, and sometimes some people may suggest this diet has to you have to take, other will suggest that it is prohibited, so much so that even the guidelines are also very flexible, and it is very difficult uh, to narrow down to a particular diet which will help the patient in the problem, in relieving the problem, in treating, curing the problem of IBS. So much so that American College of Gastroenterology does not recommend any exclusion diet. That a patient of IBS constipation should not take this. Similarly, a patient of IBS diarrhea should not take this. In other study which was conducted in the UK, it has been seen that if you exclude those foods which are associated with high IgG antibodies, probably the patient will get some benefit. And probably this study definitely hints that it has something to do with immunology or inflammation. These are, I have the pictorial depiction of the diet, the food items which are recommended. On the left side, these items should be recommended, like butter, peanut, lettuce, chicken, eggs. And on the right side, there are some food items which are to be avoided: almonds, avocado, pistachio, garlic beans. But again, you will find that these food items definitely are not the 100% sure. And I think many times I always suggest my patient that be a little intelligent and try to experiment it out, that which diet is suiting you or which diet is not suiting you. If you, and this is a hit and trial method. Suppose I have seen here they have recommended that onion and garlic should be avoided, and in other recommendations, probably you will say that onions and garlics can be taken safely. So, in my opinion, it is the physician's contribution and patient's intelligence which will devise his own diet, and he will start avoiding those food items which will create problem for him for IBS, and he will definitely be encouraged to take all those food items which probably are suiting him. And one the diet is, if it is suiting to a particular patient, may not be applicable to other patients. So you have to be a flexible when, as a physician, you are advising to adopt a particular diet. Again, a very, very interesting thing that you all know that in celiac diseases, it is the gluten, and the patient is sensitive, and we always recommend that we should avoid wheat. Patient of celiac disease, whenever he takes food item which is full of wheat, he will start having diarrhea. But in these cases, such patients of IBS, it has been observed that if they take wheat and they start having some problems suggestive of IBS. Now you will ask, then what is the difference between celiac disease and non-celiac disease, which is IBS? The sero markers of celiac disease will be absent in such cases, and there is some association with HLA DQ2 by 8 in IBS diarrhea type of patients who show some sensitivity towards gluten. Now, coming to FODMAPs, I have just talked before also. These are new group of diet items, diet food which probably cause some problem in IBS diarrhea type. This is an acronym of fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. They are short chain carbohydrates that are slowly absorbed in the and not digested. That means they stay in the gut for a longer time, and as a result, they exert an osmotic effect and they attract water through the intestinal wall. And when there is lots of water, what will happen? The patient will have diarrhea. And when they reach to the colon, they are being fermented by bacteria which are present in large intestine, and there might be some gas production because those bacteria, when they act upon these food items, they produce lots of gas and they will cause some not only bloating but abdominal pain and excessive flatulence. So this will cause change in bowel habits. So FODMAPs diet is definitely is to be avoided, especially in IBS diarrhea type of patients. But they can create problem of just like bloating and abdominal pain in constipative type as well. A meta-analysis of 6 randomized controlled trials by Marsh et al. Showed improvement in IBS severity and IBS quality of life scores with low FODMAP diet. So now there is a scientific evidence, a background also, that FODMAP diet may be a little bit part of the culprit, and they are causing some nuisance in your gut. But remember that long-term restriction is not possible, but whatever food items you have seen and which are going to see, it is very difficult to avoid all those things. So sometimes patients develop tolerance to these items, food items, and they continue taking it. This is the picture which is showing high FODMAP foods to avoid. Now vegetables, fruits, apples, peaches, plums, nectarines, pears, drinks, alcohol. Alcohol definitely is causing lots of problem of IBS, whether it is given in stable or not. Sports drinks, especially those drinks with fuzz, it will cause lots of bloating and abdominal pain. Fruit juices again will be producing lots of gas and concentrate, fruit juice concentrate. Okay. Wheat is a doubtful thing, which I have just discussed, that the non-gluten sensitivity, and corn. Similarly, others like nuts, beans, lentils, artificial sweeteners, dairy products. Now, a word about dairy products. Dairy products is again a very doubtful entity. I know lots many patients coming to me, they say that whenever they take milk, and they develop problem of diarrhea and bloating and little bit of abdominal pain. But instead of milk, if I take curd, then probably the things subside very quickly, and I feel very happy and little relieved. So, dairy products, if you labeling is a blanket ban that dairy products are harmful in IBS, it is doubtful again. So you give the choice, you give the freedom of the patient to choose whether milk is harmful to him or curd is beneficial to him or other thing. I remember when I was a student, my professor was so fond of this curd business that he normally at that time there were not many the therapeutic options available. So he used to offer curd enema to patients of IBS diarrhea type of patients, and many times the patients derive relief, maybe even temporary. So some people are very fond of consuming curd instead of milk. So again, this is your prerogative that you suggest the patient to choose one of these two. This is again this picture showing FODMAP items. Now coming to the diagnosis and a little bit of treatment. Constipation, if you excluded red flag signs and the patient is fitting with Rome 4 criteria, then try to determine which is the predominant sign and what is the stool form. If it is constipative predominant, that is IBS-C, then lifestyle modification, soluble fiber, saline and osmotic laxative. This is the purpose here is to generate more and more colonic movements, and patients should be encouraged to pass stools at least once a day, at least once in 2 days. So all these therapeutics are directed towards increasing the bowel movements like saline osmotic laxatives, secretagogues, cholokinetics, stimulants, and psychotropics and anti-anxiety agents. If it is a mixed type, then again, there has to be a treatment in between. First, I'll pick up this diarrhea predominant IBSDA and the diet. Then the therapeutic options are dietary measures. I think the dietary measures play an important and more significant role in the controlling diarrhea type of IBS. So you have to be very, very careful in suggesting particular diet to your IBS diarrhea type of patient. Anti-diarrheal agents, definitely it is recommended. Then serotonin blockers, bile acid binding agents, antibiotics. There is lots of development in antibiotics. I will be coming to that. Probiotics, antidepressants, and antispasmodic. Antidepressants, yeah, should not be picked up in a random manner. It is only the TCA, tricyclic antidepressants like imipramine. They probably are the most important because they have selective action on intestinal receptors as well. So if I am saying here that you should pick up antidepressant, then probably limit yourself to TCA or SSRI. That's it. And if the patient is having this IBS with pain, then there are certain options like antispasmodics, like dicyclomine, anti-anxiety agents, TCAs, SSRI, antibiotics, and probiotics. So the therapeutic options are entirely different in all different types of IBS, and you have to be very intelligent in choosing a particular therapeutic agent in treating your patients. Now, coming to the first part, that is therapeutic, the constipation, mild symptoms, they will be relieved by lifestyle modifications, soluble fiber, no bloating. Here, I must tell you that soluble fibers like pectin and bananas and certain something, they will be definitely more attractive. And in any case, you should avoid non-soluble fibers like bran, corn bran, wheat bran. Many times you have seen that even the physicians are recommending, oh, if you are having constipation, then increase your roughage. Roughage is fine for simple constipation, but if it is the IBS constipative type, then increasing the roughage will definitely enhance bloating and abdominal pain. So, at any cost, you should avoid non-soluble fiber and you should stick only to soluble fiber. Now coming to this problem of pain and bloating, then again the options are same, which we have just discussed. Probiotics are very important agents. I will be discussing in the end. Then, if the severe symptoms and secretagogues like chloride channel activators, lubiprostone, which I have just discussed, have been in Indian market for last 7 8 years. Cholokinetics, a few more drugs I will be discussing. Then stimulants and psychotropic anti-anxiety. So these are the options, therapeutic options, which we have to offer to our patient depending upon his functional disability. This is the dietary bulking agent that I have already talked about. Isabgol is definitely is a soluble fiber. You should recommend, but avoid at any cost this bran, whether it is corn bran or anything else. ACG Task Force gave a conditional recommendation grade 2C. Remember, psyllium hydrophilic mucocolide. American College of Gastroenterology, of course, they have given some conditional recommendation, but isabgol and something like pectin and all can be easily prescribed. Laxatives, polyethylene glycol is probably PEG is considered a better agent as compared to lactulose because lactulose is associated with bloating and cramping. While it is such type of side effects are divided in polyethylene glycol that is uh, to be given nearly half a cup of polyethylene glycol with 2 glasses of water. Always ask the patient take lots of water with polyethylene glycol because the action will be enhanced by taking extra amount of water. Then old agents like Bisacodal and Senna sodium, they uh, can still be used if the patient is suffering from constipation not relieved by the Prucalopride is approved for chronic constipation. Please remember, prucalopride is again available to us, but normally it is recommended for chronic constipation, not for IBS patients. And tegaserod is again, it was available, but now it has been withdrawn from the Indian market because it is associated with the side effect of ischemic colitis, which is a dreaded complication. Chloride channel in a lubiprostone, I have talked to you so many times before also. Lubiprostone is again what happens that it attracts lots of water. So it is good for treating IBS constipative type of patient and it is helpful in relieving the symptoms also. The recommendation is almost grade 1B. So if the patient is coming to you with IBS constipative, think of prescribing levoprostone, but the dose is only 8 milligram twice daily. It is available in two different doses in Indian market, 8 milligram and 24 milligram. Do not go to 24 milligram. That is reserved for chronic constipation. If the patient is suffering from IBS constipative type, give only 8 milligram twice daily. Then newer drugs, linaclotide and flecainide, are again guanylate cyclase inhibitors. They are also being used, but they are not yet available in our country. So whenever they will be available, it is again a recommended drug. Tenapanor is again a very interesting drug which has been introduced, not in our countries at least. And the mechanism is that it inhibits gastrointestinal sodium hydrogen exchange and it attracts lots of water. So it is helpful in relieving IBS constipative type of entity. But the side effects is diarrhea, dizziness, and distension. Guanylate cyclase, that I told you, linaclotide, lecanatide promotes intestinal fluid secretion and promote motility. But all these drugs are associated with diarrhea, so they have to be up titrated gradually and carefully. Start from a small dose and go to higher doses if the patient is not really a smaller dose because the side effect of diarrhea and then patient will give up these drugs. Now coming to the treatment of IBS diarrhea type, again the same flow chart, mild symptoms, avoid FODMAP diet and give anti-diarrhea. A word about loperamide, diphenoxylate we are not using anymore these days because diphenoxylate has been associated with paralytic ileus. Difenoxolide was earlier available in our country with the name of Lomotil, and loperamide is definitely a better drug because it is not associated with paralytic ileus. So if the patient is having mild symptoms, prescribe loperamide 2 milligram. But remember, it does not have any residual effect. So it should be loperamide should be reserved for those patients who want to have immediate relief. Like if the patient is going for a long drive, or if he is going to a place where toilet facility is not available, then you can prescribe loperamide to only for that period. I remember one of the patient in my gastro clinic. She was a lady constable, and she was most of the time put on field duty. So she was very anxious and very annoyed. Whenever I am going out on my duty, I had to stay outside a proper place where the toilet facility is available for nearly 4 5 hours, and then it is a very annoying situation that you have to search for a toilet. So loperamide should be reserved for such type of patients, and it gives only the temporary relief. Then antispasmodic, if the patient is the IBS is associated with pain and bloating, the same drugs which are recommended for constipation. And if it is the severe symptoms, then is serotonin blockers like romicitron, ondansetron, and allocitron. Romicitron is a very important drug. It is available in our country with the name of IV set. And I must tell you here that American College of Gastroenterology has recommended, and FDA has adopted these three drugs for IBS diarrhea. One is rifaximin, one is romicitron, and one is uh, probiotics, which I'll be discussing. So remember, romicitron is a very important drug if the patient is not responding to all these things. Then antidepressant and antispasmodics for pain. Loperamide, I have already talked to you. The maximum dose is 2 to 4 milligram, depending on the number of time the patient is passing stools. But anyway, you have to avoid, and especially if the patient is having fever or some other symptoms suggestive of gastrointestinal infection. So in that situation, you have to avoid loperamide, because loperamide will cause stasis, and then will be virulent luxuriant growth of bacteria which are present in the colon, because probably you are dealing with the case of infective diarrhea, and in these circumstances loperamide is contraindicated. So I have seen some prescription where they have prescribed cephaloxacin with loperamide. Probably this is not a very justified prescription, because loperamide should not be uh, prescribed if the patient you are suspecting the patient is having infective diarrhea. Then the antibiotic has been recently adopted for treatment of IBS diarrhea is rifaximin. Again, 400 milligram thrice daily or 550 milligram twice daily for 10 days. The patient becomes all right and he stays for nearly 3 4 weeks. He will be symptom free. But again, there are chances that he may recover if he will not adopt the diet which is conducive with uh, his problem. So 3 4 weeks after, if he requires, then you probably have to prescribe again this rifaximin, and then the story will be cut short by 10 days. So it is again your education, your patient education, that you have to tell him that rifaximin is good only for the time being, but ultimately you have to adopt your diet to help you out. The mechanism of rifaximin is that it changes the motility and alteration in host immune response and alteration in gut microbiota. It has been seen that certain gut microbiota are causing some problem of diarrhea. So if we are giving rifaximin, it acts like antibiotic and it kills those harmful microbiota. Another drug is 5-HT3 antagonist, which I have already talked, romistricetron has been approved by FDA for treating diarrhea type of IBS. The only thing that other drugs like velocitron or ondansetron are associated with ischemic colitis, and romistricetron is relatively safe. But this drug has you should keep it reserved uh, for treating resistant type of IBS diarrhea in women, because in women this is more incapacitating. It is more common in women IBS diarrhea, and it is more incapacitating. So this romicitron should be kept reserved for these patients. In a very interesting drug which has been introduced, it's unfortunately is not available in our country. That loxadoline. It is a selective opiate agonist as well as antagonist. It is agonist for this delta the opiate receptors, and antagonist of mu opioid receptors, and it acts locally and it is not absorbed. So it is a very interesting drug, and we can treat a number of patients with loxadoline. Unfortunately, it is not available right now. The contraindications, it causes biliary disorders because it causes biliary stasis. So it can cause some biliary sludge to develop in gallbladder, and this biliary sludge will give rise sometimes to pancreatitis if it is causing some spasm of sphincter odii and severe liver enlargement. So you have to exclude first that the patient is not suffering from these diseases, and you have to monitor as well if you are using this drug that he should not develop biliary sludge and sphincter of odii dysfunction. And probably little word about the pain, that these drugs are given for abdominal pain related to IBS, and these are all very well known. Polonium is a new drug, and which can also be used for minimizing pain, but the common side effects are anticholinergic like dry mouth, dizziness, and blurred vision with all these, amivaberine and all, dicyclomine and all. So, the College of Gastroenterology has given task force. It has been recommended only to see that antispasmodic should be kept reserved only in patients who are mm, bothered about pain in abdomen. But of course, it helps. As you can see in the bottom of the slide, that the Cochrane group system analysis has clearly showed that they help in reducing pain in IBS patients. A little about microbiome in IBS. Dysbiosis is basically is the feature that we have both types of bacteria in our colon. Some are harmful, some are beneficial. Like the bacteroids, Minococcus are some they are lactobacilli. They are all good bacteria in our colon. On the other hand, bifidobacterium, methogens, and Faecalibacterium, they are harmful, and they are uh, harmful to body, but because of these uh, beneficial bacteria, they are always in sort of symbiosis. That the beneficial bacteria do not allow the harmful bacteria to grow, and vice versa as well. But what happens when this equation is disturbed? Then patient may develop some problem, and our effort is to restore this balance. One study has shown that certain bacteria, they produce lots of methane, like you can see Arcasca kingdom group of bacteria like Clostridia and Prevotella. They'll produce lots of methane, and excess production of methane is associated with constipation, IBS constipative type, while low the IBS diarrhea type of patient, they will show low methane level. Small, the SIBO is again a very important. Small intestinal bowel overgrowth is again will cause some problem of IBS. So we have to pay attention to this entity. Probiotics are live organisms uh, which may alter gut permeability, and they are the treatment of choice these days for IBS, especially IBS diarrhea type. They are Streptococcus infantis, Lactobacillus salivarius, and all. The American College of Gastroenterology has given Grade 2C to these bifidobacteria. European Society has again recommended the use of these probiotics in patients of diarrhea type of IBS. The VSL3 is very popular in our country. It has three species of bifidobacterium, four species of lactobacilli, and Streptococcus salivarius. They are all helpful in reducing the harmful bacteria in our colon. So, um, all these, if possible, if it is affordable, then it is better to give probiotics to your patients. Probiotics not only act on gut, but they benefit in cognitive reactivity to sad mood, reduce rumination and aggressive thoughts. So even in central nervous system, probiotics are helpful. Prebiotics are non-absorbable food gradients which stimulate the growth of these bacteria. They are disaccharide and polysaccharide like fructose and inulin, reflux starch, hemicellulose. So basically, we do not give prebiotics, but natural sources of prebiotics are present in cereals, green vegetables, and plants. So we do not give in tablet form, but if we encourage our patients to take these things which have lots of prebiotic, bananas, asparagus, artichokes, berries, tomatoes, so he will be benefited, patient will be benefited because it will encourage the growth of probiotic bacteria. These prebiotics are resistant to enzymatic and chemical digestion, so when you are giving, they are most of the time helpful. Just pay attention to the last paragraph. A randomized controlled trial showed significant improvement in stool consistency, flatulence, bloating, composite symptom score, and subjective global assessment of the patient. This prebiotic mixture significantly increased fecal levels of bifidobacterium and after 4 weeks of treatment. So it has been proved scientifically also that prebiotics encourage the growth of uh, beneficial bacteria. Symbiosis is again, it is not used very common. It is the example is composite yogurt enriched with acacia fiber or yogurt enriched with bacillus coagulans. When both uh, combination probiotics and prebiotics are used, then fecal microbial transplant is a very new entity. I really like to spend a few minutes here. What happens that we take out some fecal microbiota from healthy donors. We clean it, we sterilize it, and we put into the colon of the patient, either through colonoscopic ingestion or through capsule in form of mouth, through per mouth. But remember, they are all cleaned and sterilized. So when they reach to the colon, if you are giving it through mouth or if you are going through colonoscope, they grow there and they help in relieving the patients from the problem of diarrhea type of IBS. But of course, it is not free from any adverse events. FMT is associated with abdominal pain, diarrhea, constipation, which is of course self-limiting. Long-term effect is also observed if you have transplanted fecal microbiota in a patient. It may be issue of weight gain, worsening of IBD and cancer. Cancer is, of course, a dreaded complication, so we have to study further if they are really acceptable or not. So the choice of patient is suitable for this fecal microbiota is very limited. Postbiotics is non-viable bacterial products. Bacteriophage therapy, they are all experimental, so I'm not spending time here. There, it has some legal ethical issue that if you are giving bacteriophage therapy, that means if you want to introduce viruses into the gut of a patient, they will go and kill bacteria, harmful bacteria, but it has a legal and ethical issue, so nobody is attempting it. So in the end, this is the exhaustive table which is suggesting all sorts of treatment. I understand that you have understood everything about PEG, levetiracetam, linaclotide, guanylate, cyclase inhibitors. Tenapanor is a new drug. Similarly, rifaximin is a very, very attractive option, and I think you people should not be hesitant in using the stuff if you are finding this IBS patient, especially in severe type. Allocitron and endocitron is no more used. It is the romicitron which is used. Tegasterod is again withdrawn. Pregabalin and is probably is not acting on gut, but it acts through it changes the approach, the reaction to the gut motility. Then ketotifen is again experiment drug which has been given in patients because the rationale is that mast cells are in excessive seen in gut mucosa, and it is a mast cell inhibitor. Ketotifen is a mast cell inhibitor. So if you give ketotin, probably you will tackle through this avenue. But again, it is not very, very successful. So in conclusion, let me see. Effective treatment of IBS mandates a multidisciplinary approach involving primary care physician, gastroenterologist, psychiatrist, and dietitian. Uh, The patient needs to be counseled on general lifestyle changes, regular physical activity, dietary modification, and stress management. It has been, I forgot to tell you there that physical activity, if the patient person is regularly taking exercise, it helps in IBS. Then pharmacology therapy, we have already discussed. Probiotics, prebiotics, symbiosis, we have already discussed, and that are very, very important. But you have to be very choosy in selecting your patient. IBS is gaining popularity in recently published trials, though many of them are not providing definite favorable results. Whatever drugs are available, they are not the panacea of IBS, and you have to experiment it out and hit and trial method that which drug is suiting to which patient. That was all. One thing I forgot to tell you that there are two entities which has recently been introduced in medical literature. One is post-infectious IBS, and it has been seen that if you suffer from gastrointestinal infection, especially like bacterial, maybe some viral and parasitic, then patient develops such type of IBS symptoms after 2 or 3 weeks when the infection has already been cured. So this entity is called post-infectious IBS. And another thing that it has been seen that even in inflammatory bowel disease, if the patient is in remission, then patient may develop symptoms suggestive of IBS, and then patient has to be treated for IBS, not for IBD. So that was all. Thank you very much for your patient listening. I am definitely open to any questions if you have.
Thank you, Dr. Sri. Very informative. We have one query in our chat box. A fellow colleague is asking, what is the dose of ramosetron in IBS?
Romisetron is IBCet. IBCet is available. It's a 5 milligram twice daily, but definitely it cannot be given indefinitely. So the dose is about 2 to 3 weeks.
Okay. Thank you, sir. There is a query regarding fecal microbiome transplant. Sir, is there any guideline as to at what point in the treatment do we refer a patient to this procedure, or do we wait till all the methods have been exhausted? Any guideline as such?
Yeah, it is. The FMT is not being done in every center, and normally we are keeping it reserved for only severe resistant type of cases where the patient acceptance is definitely noted. We definitely explain everything, and the patient is accepting it. Only then we go for micro FMT, fecal microbiota transplant, and as I told you that it is not even devoid of side effects, long-term side effects are also there. This is why many centers have not adopted it.
Okay. Thank you, sir. There was another query, sir. IBS in a lot of times mirrors the symptoms similar to paralytic ileus. So, is there any feature which helps us in differentiating both of them clinically?
So, in my opinion, paralytic ileus is a serious disorder. It has to be a reason behind paralytic ileus. And of course, there is lots of overlap between IBS constipative type and simple chronic constipation. And the differentiation I have already told you. So paralytic ileus, the thing is that there will not be any bowel sounds when you are putting your stethoscope over the abdomen. While in chronic constipation, it is not so. You can hear still, of course, they will be sluggish. But so this is how you can differentiate. And paralytic ileus is a type of emergency. Definitely, you have to treat the patient through various measures.
Thank you, sir. Uh, Another question in the chat box is is there any test like hydrogen breath test that is used in IBS?
And not till date, but of course, definitely we are heading towards that side only. That if we can analyze the presence of some harmful or beneficial bacteria, we definitely have to go for this hydrogen breath test to assess the growth of these bacteria in the colon. But till now, even we are not sure that which bacteria are harmful, because when we give probiotics, the effect also wanes after, say, about 2 or 3 weeks. This is why this probiotic capsules are not recommended for more than 3 months, because again patient will end up in the same problem. So we have yet to study it properly.
Thank you, sir. There is another query regarding chlordiazepoxide and clidinium bromide. These are commonly used in IBS, but are they really useful?
I told you it is the last the option. If the patient is suffering from these abdominal pain, then they are very, very helpful. And I showed you in my slide that in Cochrane analysis are clearly shown that the relative risk of developing abdominal pain is made less when you are giving this clinidium. Basically, these are antispasmodics, and chlordiazepoxide is anti-anxiety. So both the drugs are recommended if the patient is having lots of anxiety and abdominal pain. And but again, it has some side effects of anticholinergic drugs. So it has the use has to be restricted only for a few days.
Thank you, sir. Uh, any other query? If anybody has, I again repeat, they can please type it in the chat box. Sir, regarding antibiotic use in IBS, you had mentioned, other than rifaximin, is there any other antibiotic which can be considered? Because a lot of time it gets confused with infective diarrhea and people start taking Oflox or Ciplox. So does that help or do we stick to rifaximin?
Normally, the Ciplox and Norflox are not recommended because they are absorbed through systemic circulation and will create lots of side effects. So, if you give rifaximin, it is a non-absorbable antibiotic and it will act locally in the gut. So, Ciplox and Norflox is not advised unless there is possibility of infective diarrhea where you want to treat the systemic infection as well. Just if you give me 1 or 2 more minutes, I will definitely give you some guidelines of the diet, which I have jotted it down. If you recommend your patients that regular meals with moderate portion size, this is very, very important. What happens then when people go in a party, they not only eat the certain noxious, notorious food items, but they hog also. They fill their stomach excessively, and this is how they develop this IBS. So it is the food items as well as over eating is also very, very important. Drink water, avoid coffee, reduce alcohol and fuzzy drink, avoid insoluble fiber. In fact, there's lots of misconception amongst physicians. Whenever a patient comes with history of constipation, they start recommending chokar khaya karo or brawn khao or yes, in fact, that is not at all recommended in constipation. It is recommended for constipation, but not IBS constipative type. So all these things. Similarly, there is lots of doubt about the what type of vegetable, what type of food they eat. So again, as I recommended in the beginning, that you have to experiment it out. A physician as well as a patient. Intelligent patient should be taught that you have to find out your own diet.
Sir, thank you, sir. There is a query regarding is there any role of probiotic in constipation dominant cases of IBS?
Yes. Probiotics, of course, mainly it is used in diarrhea type of diarrhea type of IBS, but it helps in the constipative type of IBS as well because it enhances colonic motility. So you can use it. You can use it in both types, provided IBS constipative is a severe category.
Okay. Thank you, sir. We have a query. Do we have any definitive cure for IBS, either constipation or the diarrheal type?
Unfortunately, not because till about 2 3 years before it was considered as a functional disorder. It is the overactivity of a stimulus which is reaching to the colon in whatever form. But now, definitely, there are a number of research papers which show that there is some type of inflammation and some type of immunological phenomena which gives rise to IBS. And probably in next 2 3 years, more studies will come out. And then probably if we are tackling with those causative agents like immunological disorders or inflammatory disorders, probably then we'll have some cure.
Sir, regarding the role of anti-anxiety drugs in IBS, can you please elaborate a bit more
Ah,
on that? We have a query.
let me repeat it again. I told you anti-anxiety drugs, if it is TCA, that is tricyclic imipramine, it definitely is a preferable drug. It is a drug of choice, not because that all anti-anxiety or antidepressive or antipsychotic drugs are similar. It has particular action on the receptors of gut. So it is not only acting on central nervous system, but it is locally acting on the gut. So if you want to prescribe an antipsychotic drug, it is always TCA or SSRI, serotonin, selective serotonin reuptake inhibitor. So these two drugs are in play. Otherwise, for anxiety, if it is associated with lots of anxiety, which you can assess, then any anxiolytic like diazepam or chlordiazepoxide can be given. But if you want some action on gut also, then TCA is preferable.
Thank you, sir. Regarding the counseling aspect in IBS, as we discussed, dietary counseling is required if we have an educated patient and we can inform them about the right choices in diet. But apart from that, because we're giving anti-anxiety and stress-related medication also, so will psychological counseling also help in some extent?
Yes, of course, because you can could have seen that in conclusion, I have shown clearly that physician, gastroenterologist, and psychiatrist, then dietitian, they all four are very, very important in treating patients of IBS. So a psychiatrist is probably as important as physician or gastroenterologist.
Thank you, sir. Sir, I don't think we have any more queries today regarding the topic. On behalf of all the doctors and participants in the CME today, I thank you for such an extensive and informative session on irritable bowel syndrome. We hope to use the points that we learned today in treating our beneficiaries when they visit us in wellness centers. So, thank you so much, sir. Thank you.
Thank you, Dr. Nista, you also, because you have conducted this seminar very well. Thank you.